Okay. Real quick quizzes. Yeah, not the best. I think the one that concerned me the most, which very few people got right, was the bonus question that asked you for a motor pathway that synapsed on a lower motor neuron in the spinal cord that was influenced by the cerebellum. And a lot of my answers were something cerebellotract. Now, if it is something cerebellotract, where does that synapse? Cerebellum. So if it's saying synapsing in the spinal cord, your best bet answer is going to end with spinal. Vestibulospinal, reticulospinal, corticospinal. I even gave points to people that said corticobulbar, even though that synapse is in the brainstem, because that was the closest. At least it was a motor pathway that synapsed on a lower motor neuron. So, I get it, folks. It's the end of the semester. Brains are fuzzy, papers were due. I get it, but that was the one that concerned me the most. So if I ask you for a tract that synapses somewhere, think about what the ending should be. And similar, if I said originates from, right, then the first part of the name of the tract that you give me should be that place of origin, right? I mean, you guys have that concept down. That was just a blip, a momentary blip, right? Okay, all right. That's all I'm going to say about that. I think otherwise you will get the cerebellum down once you actually have some time to spend some time with it. So let's go back to application lecture. This morning we talked about cerebral blood supply. Today we're going to talk about what it looks like when we don't have good cerebral blood supply. And I'm going to use the term cerebral, but we're going to talk a little bit about brainstem and cerebellar strokes as well. So a stroke is sometimes called a cerebral vascular accident, or CVA, as you will see abbreviated on medical documents. Again, if you see cerebral vascular accident, it's usually referring to occlusion of a cerebral artery, which would be like our ACA, our MCA, or our PCA. But in general, strokes can occur anywhere. So they can occur in the diencephalon, they can occur in the brainstem, they can occur in areas of the cerebellum, or even the spinal cord. It is the most common neurologic disorder that we see, at least in adults. And so you will see a lot of stroke clients if you're working in a hospital setting, whether it's acute, subacute, inpatient, and you'll still see a lot of clients, probably in outpatient as well. It's the third leading cause of death in the U.S., and at least 50% of people who have a stroke will have some type of permanent neurologic disorder. And another third of those people who have a stroke will have a second stroke. And just a reminder that if we are talking about strokes, we are talking about disorders that are going to look like upper motor neuron disorders, or these are upper motor neuron disorders, okay? Because we're damaging those neurons, or that cortical area that is going to project down to the lower motor neurons in the spinal cord, right? So that's important to keep in mind. There are two types of stroke, and I apologize if I am repeating from the lectures. I don't think a lot of this will be repetition, but some of this intro stuff may be. A stroke, or a CVA, is going to be some type of compromise to blood supply in the brain. And there's going to be two major categories of stroke: hemorrhagic strokes and ischemic strokes. Did you guys differentiate these in the lectures? Yeah, okay. So hemorrhagic is going to be when there is a bleed into the brain. It's a rupture of a blood vessel that leads to bleeding into the brain, and is usually due to hypertension or high blood pressure, or an aneurysm. And an aneurysm is a weakening of the walls of a blood vessel, and usually what happens is that we have a ballooning out and eventually a rupture of that blood vessel. Trauma can also cause bleeding in the brain, and it's not always considered a type of stroke, but it's a similar type of end goal, or end product of that. You're getting bleeding into the brain, a lack of blood supply now to a certain area of the brain. The more common type of stroke, about 13% of all strokes are hemorrhagic. The rest are ischemic or occlusive stroke, meaning that blood supply is occluded to a specific area there are two types of ischemic strokes, embolic and thrombotic. Embolic is going to be more sudden, so there is a release of an embolus or a release of usually plaque, some type of object, from a vessel that is going to lodge itself in a cerebral artery. So in this case, it's a clot in the MCA. This one would be a blockage of the internal carotid, and this isn't a full blockage. But a piece of this could dislodge and end up in one of those branches that we talked about of the internal carotid today. What were the four main branches of the internal carotid that we talked about? MCA, ophthalmic, anterior choroidal, anterior cerebral. Those were the four off the internal carotid that we talked about. A thrombotic stroke is going to be a gradual reduction. So that would be like this, arteriosclerosis, I'm horrible with these, is a buildup of plaque over time, eventually leading to a blockage or a significant reduction in blood supply. So we'll do a quick video on stroke. Again, this one's short. Hopefully you haven't seen
This program is
yet.
brought to you by Emory University.
There are two broad categories of stroke. There is what is called ischemic stroke. That is when the brain is deprived of blood supply. The human brain requires a constant supply of well-oxygenated blood. And if it's interrupted for more than a few moments, the brain begins working inappropriately, or quits working, if you will. If the brain goes for more than a few minutes without blood, it actually dies. Because unlike other organs in the body, the brain does not have the ability to store oxygen and glucose. It gets it from the bloodstream. A second type of stroke is called hemorrhagic stroke, and that's when there is actually bleeding into the brain or the space around the brain. And that can occur from a variety of conditions, such as chronic high blood pressure, which can weaken arteries in the brain and cause hemorrhages. One of the more common causes of bleeding into or around the space of the brain are brain aneurysms, weak spots in the wall of a blood vessel that balloon out and can burst and bleed. A hemorrhagic stroke, where there is actually bleeding into the brain or the space around the brain, typically presents with a sudden onset of the worst headache of one's life. If one has to wonder whether their aneurysm bled, for example, it probably did. It's usually an unmistakable event. Sometimes a brain aneurysm can cause symptoms prior to rupturing and bleeding. If an aneurysm is enlarging prior to bleeding, it can put pressure on cranial nerves within the brain and cause double vision or altered vision, and on rare occasions that can be a warning sign. But usually it's a sudden onset of a severe headache. Ischemic strokes, strokes caused by a lack of blood flow to the brain, are frequently preceded by what's called a transient ischemic attack, or a TIA. A TIA is simply the symptoms that are produced when the brain temporarily goes without an adequate supply of blood. They're characterized by transient episodes of maybe numbness or weakness on one side of the body, transient loss of vision in one eye or the other, temporary inability to speak properly or garbled speech, temporary symptoms of unsteadiness or dizziness that come and go. And unfortunately, many people are not aware that those are the warning signs of stroke, and they ignore them. And when those occur, patients really should urgently see their physician to be evaluated, because oftentimes these warning signs portend a much more severe and permanent stroke in the near future. And oftentimes there are things we can do to reduce that risk or even eliminate that risk if the symptoms are recognized and treated appropriately.
So again, probably some repetition there and things you could have already heard. So let's focus on you guys have like the whole slide, right? Time out. Hold on. Alright. I'm not gonna mess with that. Alright, I'm just gonna show it here for a second. I don't know why the things won't pop up. MCA strokes, most common type of stroke. We already talked about today that it's covering most of your motor, your primary motor cortex and primary sensory cortex, or your pre and your post central gyrus, mainly the arm face region or upper extremity and face region. And so an MCA stroke, loss of supply to these areas is going to result in contralateral paralysis of usually the arm, the face, and the tongue would be involved as well. So again, those corticospinal, corticobulbar tracts, those upper motor neurons are damaged. You lose that function. Because of the sensory strip here, we're also going to have contralateral somatosensory loss. And we talked about this morning that the MCA is covering the language areas of Broca's area and Wernicke's area, and Broca's, the superior division of the MCA is occluded, then we're more likely to have Broca's, again, just on the left. And if it's the inferior division, we're more likely to have Wernicke's aphasia. So Broca's area, expressive language, Wernicke's, receptive. Because the MCA covers so much territory, there are other deficits that we could see. I mentioned this morning deficits in perception and object recognition. Again, that ventral stream of the visual pathway that's projecting back up to the cortex from the primary visual cortex. If it damages the optic radiations or the optic tract, because the MCA does supply both of those to some degree, in addition with the anterior choroidal, you could have visual spatial deficits or hemianopsia. And sometimes with MCA deficits, people have a lack of awareness of their disability. So they don't realize that they have a sensory loss or a motor paralysis. And this is the fancy term for that, anosognosia. I don't know, you guys can look that one up. But that would be something to look for in a clinical case. And if you see that, it's something that you would think, yeah, that's probably MCA, as opposed to another type of stroke. Wow, okay, these are all jacked up. This is what I get for using adding to other people's slides. So I'm just gonna go like this. So anterior cerebral artery or ACA stroke, again, this is gonna be covering, expand this real quick, this medial region. So when we looked at it today at the mid-sagittal, it's covering most of the midline. In terms of the motor and the sensory homunculus, it's covering primarily the lower extremities and some of the trunk. So if you have a stroke or occlusion of the ACA, what you're going to get is contralateral, lower extremity weakness or paralysis. You may get some involvement of the upper extremity just because that blood supply is not completely, doesn't draw a clear line down one or the other, but you're primarily going to see weakness in the lower extremity somatosensory loss. This would be contralateral. Again, you can write that in there. I didn't put that in there. Contralateral. With an anterior cerebral artery stroke, you could get apraxia. Why do you think, what part of the brain do you think you would be damaging in an anterior cerebral artery stroke? Let me go back to premotor cortex, and even specifically looking at this lateral aspect, remember ACA is in yellow, you're going to be getting into the SMA, probably. So yeah, damage to those premotor areas that are responsible for motor planning. Not that you couldn't see that in an MCA stroke, but probably more often in an ACA. And I mentioned this morning too that the anterior cerebral artery, because it covers a wide swath of this frontal cortex and prefrontal cortex, also the cingulate gyrus, then ACA stroke could result in behavioral, emotional, or intellectual changes. And some of the ways that might manifest would be confusion or disorientation, possibly distractibility or inattention to task. So when you go in, hold on Dustin, 1 second. Like, how many of you guys, when you've done if you did acute, maybe even inpatient field work, they look to see if the person was alert and oriented ×3, so they're asking their name, the date, and I forget what the 3 things are because it's been a long time, but how many of you guys saw that? And they would document alert and oriented ×3. So they're looking for these sorts of things. Do they know where they're at? Do they know who they are? Are they demonstrating any level of confusion? So that's something, again, that in an initial report or examination, case, you would want to see, is that person alert and oriented? It might give you a sense of where the damage is, probably frontal lobe, probably ACA, could also again be MCA because it's supplying some aspects of the frontal lobe as well. Dustin?
Does this relate to like vascular dementia?
Vascular dementia?
Yeah, I just remember my grandmother had TIA, and she developed what it was diagnosed with vascular dementia. So
I would think so. I'm not really that familiar with that term, but it sounds like essentially you're saying there's a lack of blood supply probably damaging these areas.
I mean, she had a lot of confusion and like mood swings.
Yeah, so I mean, I would guess that this area was part of the region that was not getting a good blood supply. Not that others couldn't be compromised as well. Right, okay, posterior cerebral artery. This one's a little more complicated because if you remember, the posterior cerebral artery covered parts of the cerebral cortex, particularly the visual cortex, that was a big part of it, but also parts of the inferior temporal lobe, if you remember coloring in that part. And it's also going to cover a wide swath of the diencephalon, including the thalamus and the subthalamic nucleus. So we may see with a PCA stroke, we often see homonymous hemianopsia. So again, a loss of a right or the left visual field. All right, so visual field cuts. Because we are losing that part of the inferior, so this would be due to loss of the primary visual cortex, homonymous hemianopsia, and PCA injury is going to be due to a loss of the primary visual cortex on either side. Memory impairments are probably going to result from loss of the inferior temporal lobe. And we didn't look at the inferior surface of the brain, but if you think about that inferior temporal lobe, we've got like the parahippocampal gyrus down there, the fusiform gyrus down there. So those parts of the brain that we attribute to memory and learning. So we could have learning and memory impairments with a PCA stroke because of damage to the inferior temporal cortex. Now the PCA is also supplying parts of the midbrain, including the motor nucleus for cranial nerve 3. So sometimes you get what's either called third nerve palsy or oculomotor nerve palsy, and that's either damage to the nucleus itself or those oculomotor fibers that are going out to the eye muscles. So either damage to the fibers or the nucleus could lead to oculomotor nerve palsy. Also within the midbrain, the PCA helps to supply the superior cerebellar peduncle. Helps to supply, doesn't give full supply to it, but we could see ataxia with some types of PCA strokes. Again, you're not getting that information from the cerebellum. It's that motor circuits coming out. SCP sends things out, right? And then with damage to the cerebral peduncle, that's where our corticospinal and our corticobulbar fibers are traveling. So we could also see hemiparesis with a PCA injury. And then because it does cover thalamic and subthalamic nuclei, sensory loss would be seen with damage to the thalamus. It could be a diverse spread of sensory loss. It's not specific like a contralateral sensory loss or loss of the system. We know the thalamus is complex. We know there's a lot of different nuclei. But damage to the subthalamic nucleus, we talked about this morning, would result in hemibolism. All right, so those uncontrolled, jerky movements that we talked about when we talked about basal ganglia lesions. So this is tough, you know, in terms of presentation, because it could look very different in a lot of different people. There are 3 common conditions that we're going to talk about that are all due to a PCA stroke, and they tend to be, again, the symptoms tend to group together, and so they're called isolated syndromes. The first one is called Weber's syndrome, and it has a midbrain basis, meaning it's loss of PCA blood supply to the midbrain in particular. And I showed you this picture in the morning. that this light pink and dark purple is all supplied by the posterior cerebral artery. And so Weber syndrome is defined by two primary features. One is that oculomotor or third nerve palsy, which is going to be an ipsilateral paresis of adduction and vertical gaze. And so you see in this picture, this is the normal eye, this is on the left. The right eye, so if it was the right oculomotor nerve or nerve fibers that were damaged, you're going to lose your downward, or there would be a downward outward gaze because you're losing adduction and you're losing the ability to bring the eye up. So that's where the palsy is. Because the oculomotor nerve also dilates the pupil, you're going to have, constricts the pupil, you also have a dilated pupil. And the cranial nerve 3 also controls elevation of the eyelids. So you get a condition called ptosis, which is eyelid drooping. So all of those symptoms together constitute oculomotor nerve palsy. And again, it would look like an eyelid droop, the eye down and out, and sometimes having the pupil dilated. And the eye that is affected is the side that's affected. It's ipsilateral. Often in Weber syndrome, there's also this damage to the cerebral peduncles, and therefore you may have paralysis of the contralateral, face, arm, and leg. All right, all three of them, because you have both corticospinal, arm and leg fibers, and corticobulbar fibers traveling in this dark purple region here. So again, in ACA stroke, you're thinking, looking for lower extremity primarily. In MCA stroke, I'm looking for primarily arm and face paralysis. And with a PCA stroke, if it's something like Weber syndrome and it's affecting the cerebral peduncle, I'm going to see arm, leg, and face affected. Does that make sense? Sure. So with an ACA stroke, primarily going to be lower extremities. We're talking paralysis. We're just talking motor right now. With an MCA stroke, it's going to be primarily paralysis or weakness in the arm, upper extremity, and face region. Again, contralateral. And then with a PCA stroke, at least with Weber syndrome, you're affecting all of these corticospinal and all of these corticobulbar fibers, so you're going to see arm, leg, and face. Again, still contralateral, that hasn't changed. These fibers don't cross till they get to the medulla. But the distribution of the functional deficit is going to be different depending on which of these cerebral arteries is damaged. And this cheat sheet, I know you haven't had time to look at it yet. I'm calling it a cheat sheet. It's a handout. But it breaks it down for you what MCA, ACA, and PCA strokes would look like, and based on left or right hemisphere. And with the MCA, it does do that division for superior, inferior, and deep branches. And then when it says MCA stem, it just means if all three of those are affected. And that's written in the paragraph at the top. But this would be a good study guide as you're trying to distinguish which of these arteries are affected when you have cerebral damage. I said there were going to be 3 syndromes we were going to look at that were mainly PCA related. So Claude syndrome is the next one. And there's damage usually or loss of blood supply to 3 primary structures. One are oculomotor nerve fibers, also called fascicles. So those fibers that are leaving the oculomotor nerve and traveling up to the eye muscles. The red nucleus and superior cerebellar peduncle fibers. And again, these are supplied primarily by the PCA, also branches of the basilar artery. And the 2 primary symptoms we're going to see with this, with Claude syndrome, are again ipsilateral oculomotor nerve paralysis, same symptom that we saw here, okay? But also contralateral ataxia and tremor, because we're getting damage to the superior cerebellar peduncle. So, again, Weber's, oops, oculomotor nerve palsy, and possible paresis. Claude's oculomotor nerve palsy and ataxia. Benedict's is kind of the worst of them all, because you're gonna see oculomotor nerve palsy, you're gonna see some ataxia, you're gonna see some hemiparesis, and you're also gonna see involuntary movements, and that's because the substantia nigra is also involved. Don't forget substantia nigra lives in the midbrain as well. We didn't really talk about it in relation to PCA blood supply, but it's in that same region. And so we're having damage in Benedict syndrome to the oculomotor nerve fibers, to the cerebral peduncle, to the red nucleus, to the substantia nigra, and to fibers of the superior cerebellar peduncle. So this is going to be more pronounced, more involved, and the really distinguishing characteristic of Benedict's is that there's loss of blood supply to the substantia nigra, affecting the basal ganglia, which is going to lead to involuntary movements. Yes.
So for Weber's, we're talking about how it's the face, arm, and leg. And for Benedict's and Claude's, when you say ataxia, remember, is it of the face, arm, and leg also, or?
It will be. And remember, Claude's doesn't have hemiparesis, so it's not going to be an issue
Or, I mean,
here.
ataxia.
But the ataxia probably will be all over, will be a global, it could be trunk and extremities. And same thing with Benedict's. So again, it's contralateral, but it could be arms, legs, trunk.
Same with hemiparesis.
Hemiparesis would be,
All of
could
it.
be all of them, because again, it's affecting the cerebral peduncle that's carrying all of those fibers. We haven't left the midbrain, so they're all still traveling together. Okay, so those are your book, I think it's the chapter after the one I asked you to read on blood supply, but it goes into a lot of other syndromes. I don't know if you guys are going to sell this book back or what, but I mean, it's a good reference if you get a funky diagnosis on a medical chart during field work, because it goes through probably 20 other types of specific strokes or specific syndromes that I'm not going to make you learn for this class, but they're there if you ever need a reference. These are the 3 that I want you to know. Okay, so those were all cerebral artery strokes. I want you to be familiar with the term lacunar strokes, and this is a general term that's related to any time smaller branches of a larger blood vessel become occluded, and usually it's branches that are kind of diving deep down into diencephalic area, and the 2 areas that are usually affected are the internal capsule or the thalamus. So remember, the thalamus was supplied by branches of both the MCA and the PCA. Branches diving down. The MCA was supplying the anterior limb and the genu of the internal capsule, and the PCA, anterior choroidal was supplying the posterior limb of the internal capsule. And so, based on where these lacunar strokes happen, we can typically get 3 types of deficits. We can get pure motor, meaning that we just have motor paralysis. And again, based on where it is, legs, trunk, arms, or face, generally if we have damage to the posterior limb, we're looking at paralysis of the legs, arm, and trunk. It may or may not be the genu. We could get pure sensory loss, particularly if the damage is to areas of the thalamus. Or if we lose the whole internal capsule, we could end up with a combination of motor and sensory loss. So there's really no one presentation of this, but you need to know that these exist and that these can be part of the mix when you're looking at clinical presentation. So again, this would be another situation where you could have just motor loss, but motor loss contralateral in the arms, legs, and trunk, because you would only be getting damage to the posterior limb. So that would look different than an ACA stroke. It would look different than an MCA stroke. And probably with a PCA stroke, you could have some of this paralysis, but you're gonna have other symptoms as well, right? Because you're probably gonna be affecting the midbrain or the visual cortex. And in general terms, we talked a lot about the cerebellum last week. There are three primary arteries that are supplying the cerebellum: the anterior inferior cerebellar artery, the superior cerebellar artery, and the posterior inferior cerebellar artery. Loss of blood supply to any of these could resolve, or usually results, in the following symptoms. And this again is just really general, but ipsilateral ataxia. So if the damage is to the cerebellum itself, we get ipsilateral ataxia, and if the damage is to the area of the vermis, here or here, which is primarily going to be the superior and the posterior inferior arteries, we're going to get truncal ataxia. And if it's out more in the lateral hemispheres, the lateral cerebellar hemispheres, we're going to get appendicular ataxia, meaning more appendix extremities versus the trunk. We can also have the following symptoms: facial analgesia, which, remember, the ACA provides midbrain innervation as well to the trigeminal nucleus, which receives information from sensory receptors in the face. And so if it's ACA damage, or AICA damage in particular, we could have loss of sensation from the face. The AICA also supplies the vestibular nuclei, so we could have nausea and vomiting and nystagmus. And that could really, those two really could be from damage to other arteries as well. Like a general cerebellar loss could lead to problems with nystagmus, potentially nausea and vomiting. So that's not isolated to AICA injuries. Other things that we can see are characteristic of cerebellar disorders in general: unsteadiness, falling to the side of the lesion, dysphagia, difficulty swallowing or coordinating the motor actions needed to swallow, dysarthria, problems coordinating the motor actions for speech. And I mentioned earlier that sometimes if we are compressing a ventricle, we can get headaches and hydrocephalus. And so damage to these arteries can potentially cause compression of the fourth ventricle, because the fourth ventricle sits right here. Okay, so any of these, if there's a hemorrhage or increased pressure in any of these arteries, we could compress the fourth ventricle, and you would see that manifest usually as headaches, and then eventually hydrocephalus if the problem isn't corrected and the drainage isn't shunted. So we'll talk for a minute about interventions. Those are the main types of stroke I want you to be responsible for. Again, I would encourage you to use that handout as a sort of cheat sheet, at least for the cerebral blood supply. In terms of medical interventions, and again, these aren't things you would be applying, but you should know about. If it is an ischemic stroke, there is a clot-dissolving medication called tissue plasminogen activator, or TPA, that goes in and can dissolve the clot and restore blood flow. It can only, did you guys learn about this one in med lectures?
Time it.
Huh?
This is the one you have to time.
Yeah, what was their marker for how soon you had to give it after the clot forms or the clot symptoms started? 3 hours. Okay, that's the same marker I have. They will still administer it, I believe, up to 6 hours, but the general consensus is that it needs to be administered within 3 hours to really be effective. And the other thing is that it's contraindicated for a hemorrhagic stroke. So in a hemorrhagic stroke, something bursts, you kind of want it to seal up and close up. You don't want to create more blood flow. So it's contraindicated for a hemorrhagic stroke. Hemorrhagic strokes are a bit more challenging to control. Usually it's medications that are given preventatively to control blood pressure. or blood sugar levels, or if there are fevers or seizures associated with it. And if there is swelling in the brain, that there are medications that you can give to reduce inflammation and reduce swelling. Preventatively, you can take aspirin when there is a carotid stenosis. So when the internal carotid arteries, there's a buildup of plaque or buildup of blood clots in particularly the carotid arteries. So the aspirin reduces platelet aggregation, can reduce the formation and release of blood clots, particularly in the internal carotid arteries. Aspirin also reduces inflammation in general, and inflamed plaque is a lot more dangerous than just regular plaque. So that's another function of aspirin as well, is to reduce the inflammation in those vessels. And then if it's caught early enough and people know they have blockages in their blood vessels, they can get a surgery to remove the plaques that are forming. So I know my uncle had one or two of these done. They go in and they kind of clean you out and take the plaque out when there is an area of serious blockage. So again, these are preventative interventions. In terms of interventions and evidence base for interventions, a lot of work has been done with animal studies, again, really looking at changes in the brain following stroke. And I've seen this done. They'll go in for surgery and they'll have the little rat or mouse on the surgical table, and they have very precise instrumentation to go down, and they will just have, essentially they'll make a little incision and they'll have a little probe go in and go bzzz, and they will cause an MCA stroke or an ACA stroke or whatever, because they're trying to cause a certain type of functional deficit, and then they rehabilitate those animals. And so, yeah, these are some of the rehabilitation techniques. You might see something like this in humans as well, like a gait trainer. But the research shows that not only do you see functional improvements, but there are, with practice, with repetition, and engagement in activities, changes in the brain. There's electrical activity, particularly in the brain regions that are adjacent to those that have been damaged. And so we, again, have talked about neuroplasticity in several lectures, but we know that areas surrounding the damaged tissue can start taking over, and they might take over some of the same functions. They also may take over to do their own thing. But in this case, if they're practicing using the damaged limbs, they do constraint-induced movement on animals as well, then we can get some level of recovery in the damaged limb. Now, when we talk about occupational therapy interventions, in terms of assessment, when you go in to assess, you're going to be looking not just at motor function, but you're going to be looking at sensation, range of motion, muscle tone, cognition. And I have perception up here. You'll look at perception, but you're also going to look just at general visual abilities. Do they have a visual field loss? Where is it? Do they have any level of neglect? And then how are those areas affecting their occupational performance? Are they able to dress themselves? Are they able to sit edge of bed? Are they able to get up and walk to the bathroom? Are they able to feed themselves? So your assessment is going to cover a lot of different things, and sometimes in acute care you have about 5 minutes to assess all of these things, so you need to be pretty efficient at it. And then when it comes time to choosing your interventions, you have another slide in your handouts, I just skipped it. You want to think about what is there an evidence base for? Why am I doing the things that I'm doing? And so this is sort of a summary, and I'm looking forward to reading some of your papers, because some of you guys looked into other interventions for stroke, but we talked about early on in the semester that there's fairly strong evidence for the use of constraint-induced movement therapy in the case where there is contralateral paralysis, hemiparesis. That by constraining the non-affected limb and forcing use in the affected limb, we can get improved functional use of that affected upper extremity. Some other things, again, we've talked about all of these in the context of other lectures, that there is at least some, if not moderate, evidence for Things like mental practice, again, particularly if we're thinking about damage to the motor cortex or premotor cortices, can we visualize, can we practice and get increased repetition just by imagining doing the task, pretending like we are doing it, going through the motions in our head. We haven't talked much about virtual reality, but it's that same kind of concept, and you'll talk about that with Tony next semester. But again, it's another way of practicing without actually having to necessarily do the task or do all of the task. We know that through motor learning principles that repetition and practice is going to help with functional recovery, and you need to practice what you want to do. So if you want them to be able to brush their hair, okay, so this motion, or whatever you guys use, okay, then you need to practice brushing hair, that by having them stack cones or move rings from one side of a board to the other, what they're going to get good at is moving rings from one side of the board to the other, or stacking cones. We're not necessarily going to transfer that to being able to brush their hair. So the repetition and the practice needs to be repeating the functional skill that you want them to be able to do. And then I think it was last week or the week before, we talked about the use of functional electrical muscular stimulation, or FEMS, as a way to facilitate muscle movement, and repetitive transcranial magnetic stimulation, again, usually inhibiting the, kind of like constraint-induced movement therapy, inhibiting the non-affected side to get activity in the affected side, or sometimes stimulating the affected side. It kind of depends which way you want to go with that. But all of these have some level of evidence to use in occupational therapy for treatment of stroke. So, kind of pull it all together for today. It is important to know cerebral blood supply, to understand the types of functional loss or functional deficits you would expect to see. I would encourage you to come up with a soundbite that defines stroke in the three major cerebral arteries, the ACA, the MCA, and the PCA. Also to have a general idea of what you would expect to see in brainstem or cerebellar lesions. The three main brainstem lesions, mainly midbrain that we talked about today, were related to the posterior cerebral artery, Weber syndrome, Claude syndrome, and Benedict syndrome. And being able to come up with some interventions that have an evidence basis for treatment of stroke. So if I gave you a clinical case and I asked you to work through, where's the lesion, what does this look like, blah, 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 and then I say, what are you going to do with this client? Give me something that has an evidence base to it, then I'm probably looking for something like this, and for you to be able to rationalize why you would use that. Yes?
Just a quick question about interventions. Most of those are targeting the, developing motor function.
True.
Are there interventions that are evidence-based for sensory?
In terms of stroke, off the top of my head, I don't know. We talked about pain reduction and desensitization, but in terms of actual sensory loss, I am not sure. If you're treating visual deficits as a sensation, then you would talk about setting things up on their affected side, getting them to look and orient to that side. But in terms of somatosensory system, I am not sure about the evidence base for that. All right, we have time. Oh,
I was just gonna say, if you're doing the motor, training, functional motor training, you're gonna get a lot of tactile feedback with the five-section, so I'm sure that side's gonna be activated, so you're gonna have a return of both motor and sensory.
You're going to be stimulating both, but I don't know about the research in does that actually improve tactile discrimination if you go back and retest that. I don't know what's out there. That would be a good paper for somebody to do next year. Okay, let's do one clinical case before we break, just to give you an idea. So don't cheat and look at the last page, because that does have the answer. See if you can work this one out on your own. toss your idea to the person next to you and see if they came up with the same thing. Or person behind you. Justin and Paige, you both seem
But I was like, I'm too tired. I'm so busy going out.
So probably.
Let's go ahead and go through this together real quick. And then there are two other practice cases, and these are not out of your book, so there's still the questions at the end of the book, at the end of the chapters that you can use as well to practice. But let's go through. So if somebody's alert and oriented, what does this kind of tell us? Where would we think there's not damage? Okay, so probably not frontal lobe damage if they're alert and oriented, which tells us probably not ACA, maybe not MCA, but we're thinking, we're not talking about frontal lobe here. Speech is fluent. So what are we thinking here? What must be all right? Okay, Broca's area for one, so frontal lobe, which is supplied by the MCA. We also might have disfluent speech if there was damage where? Cerebellum. So we're kind of thinking, frontal lobe sounds okay, cerebellum sounds okay. Gait normal. Cerebellum seems okay. What else seems okay? Okay, probably the motor cortex, because if we're moving our legs okay, at least the ACA area of the motor cortex is okay. Also probably basal ganglia is okay, right? If gait's completely normal, as you're going through, probably. Sensation's intact. So again, what's all right? Post-central gyrus, right? So that's parietal lobe, supplied by both the ACA for the lower extremities and the MCA for the upper extremities. Sorry?
Does it also include like the vertebral artery? That could impact the
Right, so good point. So it sounds like if sensation's intact, then our dorsal columns are intact. So that could be the spinal artery, the dorsal spinal artery. It also means that the DCML is okay as it courses through the brainstem. Right? So that was the superior cerebellar artery that helps supply the DCML, at least in the midbrain area. Eye movements are okay. So they're able to move their eyes in all planes, visually track in all planes. So what is that telling us? It's telling us that our oculomotor nerve nuclei in the brainstem, usually most of them in the midbrain, are okay. We don't have damage to the oculomotor nerves, the abducens, the trochlear, or the oculomotor, abducens, or trochlear. Sorry, those three. For the muscles, the muscle movements are okay. We have normal muscle tone. probably okay in the vestibular nuclei. So again, that's kind of ruling out that, some of those midbrain nuclei supplied by the anterior inferior cerebellar artery. And again, we have normal muscle strength and sorry, I already said muscle tone, but normal muscle strength. So able to move the extremities through full range of motion and hold against resistance. So what is okay? Cerebellum gives us more quality of movement, the ability to command and execute motor movements. It's probably telling us that M1 is intact, right? Areas 4 and 6, I guess. And that's upper and lower extremities, so pretty much there's a pretty good case here. Oh, and I skipped over normal fingered nose, so what is that telling us? Cerebellum's cool. So pretty much the evidence up to this point is that cerebellum's good, precentral gyrus or motor cortex is good, postcentral gyrus is good, dorsal columns seem okay, cerebral peduncles and pyramids seem okay. So the last symptom we have is visual field testing identifies a positive right homonymous hemianopsia. So what are some areas that could be damaged that would give us homonymous hemianopsia? I don't want arteries, just give me areas. Visual cortex, optic radiations, or optic tract. Well, optic radiations and optic tract are supplied by what arteries? The MCA, middle cerebral, and anterior choroidal. Anterior choroidal also supplies like basal ganglia, a little bit of thalamus. There's no evidence for damage to those areas, and we've already kind of ruled out most of the MCA territory. So, it sounds like that the lesion is where? Primary visual cortex, on which side? Left, which is supplied by the posterior cerebral artery. That is your answer. Left primary visual cortex, supplied by the posterior cerebral artery. And note that the client, when she came in, said that she lost her vision in the right eye. Even though the loss is in the right visual field of both eyes, a lot of people will complain of or say they've lost vision in their right eye, when really they've lost the vision in their right visual field. That's why this is in quotation marks here, but the examination shows right homonymous hemianopsia. So that's how you need to approach these cases. You need to look at the presentation, look at the examination, rule out things as you go, and then focus on what the positive symptoms are and what could be causing it. Okay, I know this is a lot for today, so I would recommend, there's 2 more cases here. I would go back through your notes, study for the quiz next week, and then go and try and do the other 2 cases and see if it gets any easier. Okay?